My name is Callie Hayes, and I will be discussing my leadership change project in this presentation. I used the P-code template when trying to create my research question. To put it in layman's terms, it's essentially questioning whether more patients die in rural West Virginia hospitals compared to urban West Virginia hospitals due to staffing shortages and higher nurse-to-patient ratios. So for the population, that would be for nurses in southern West Virginia at trauma level 3 or 4 hospitals, working in an ICU or CCU unit, intervention being, does higher nurse-to-patient ratios, outcome being, yield increased length of stay compared to ICU or CCU units in trauma level 1 and 2 hospitals in the state, and my comparison being that have lower nurse-to-patient ratios. I chose this topic because I am a new nurse, and even at 10 weeks in, working, I can see the stress on nurses when patient ratios go up. I have friends who work in local ICUs, and they term it as terrible nurse-to-patient ratios and experiences. And I hear about more poor outcomes than I do good outcomes. It's a genuine interest of mine because I went through similar situations and saw a lot of bad and some good, but more bad when I went through all of the ICU visits with my father before his passing. For my research design, I chose a longitudinal study. Essentially, that's a collection of data from the same sample across an extended period of time. It seemed to be a better option than a cross-sectional study because you can find casual inferences or casual conclusions, which are essentially just the effects from a particular phenomenon. With that being said, when doing this research project, you would need to have some controls, such as age and sex adjustments within your cohorts, because if you pick rural hospitals, you're likely going to see an increase in elderly population because there are more elderly in those rural places typically. So you need to have a cap on, I'm going to have this many females, this many males, and so many from this age range to that age range. We want to, while doing the research project, we want to look for ways to improve wellness procedures for nursing staff, so code lavenders, and just general employee health for when things do get hard. With this research design as well, there's going to be data flaws. Like I said, rural communities have higher populations of old people, so it's going to somewhat skew the research data one way or the other. So it's important to try to put a cap on different variables within the design of the research project. To discuss this just slightly further, I really just want to know, why is there a nursing shortage in our area? Does it go beyond nursing? Is it providers? Is there a shortage in providers? Are providers unhappy? Is it the provider quality of care? Is it a lack of patient education? A lack of healthy lifestyles in these areas? And again, comparing southern West Virginia as well as other rural places in West Virginia, urban places in West Virginia, and comparing that to the whole United States and the rest of the world. The nurse-to-patient ratios do differ in various places, and there's a lot of factors that can play a role in the outcome of this. So population, income, gender, sex, age, socioeconomical status, religion, regional pollutants and toxins, resources such as transportation, health insurance, health care, quality, and education, comorbidities, and the list continues to go on. For my problem statement, it's due to short staffing and high nurse-to-patient ratios, there is a risk of increased mortality and negative outcomes. So the higher the nurse-to-patient ratio is, the harder it becomes for nurses to give quality care. If care is left undone or it's done subpar, patients suffer. If care is too much to handle, errors are going to be made, and when errors are made, the patient's safety is put at risk. It's a domino effect, and it comes full circle. And instead of continuing to let it happen, we could resolve the issue by mandating organizational and state policies that are in favor of the nurse and the patient's safety. There are a lot of outcomes with doing a research project like this, but the main points are trying to find the percentage of good outcomes, so how many patients are being discharged amongst these different areas, how many patients are having poor outcomes, such as mortality rates or readmissions, and we need to just frankly determine the nurse to patient ratios in these different areas to see what the differences are. As a community, state, and nation, we should constantly be evaluating best practices and conforming to needed changes to prevent unnecessary patient death and to reduce overall mortality rates in the hospital setting. One of the main research articles that I used in my essay was the policy that California has implemented, and it's a mandatory patient cap for nurses, and it's yielded extreme success. Safer nurses means safer patients, just like I stated, and this is something that needs to be implemented nationwide. So when examining data from all 50 states, the study found that the California RN staffing ratios law was associated with a 31.6% reduction in occupational injuries and illnesses amongst RNs working in hospitals in California. So along with trying to reduce errors and negative outcomes for patients, we also want to reduce negative outcomes on the nurses. In another study, the odds of patient mortality increased by 7% for every additional patient in the average nurse's workload in the hospital. And that difference from 4 to 6 patients and from 4 to 8 patients per nurse would be accompanied by a 14% and 31% increase in mortality rates, respectively. That's an insane increase that we should be able to prevent and mitigate. Talking about how this can contribute to new knowledge in nurse leadership practice, I want to talk about quantum leadership and the practices with that. So rather than nurses functioning as one unit of a whole, they need to work more as a team. We sometimes see this in codes or rapid response calls in the ER, but we don't see it nearly as much when it's in separate nursing assignments. So in the ICU setting, as well as the ER, med-surg, and everywhere else. But one nurse could have 3 high acuity patients and 1 low acuity patient, while another nurse only has 2 patients in their section, and they're both low acuity. So that nurse with the easier workload could help the other nurse with patient care to improve outcomes, such as meeting sepsis protocols and stroke protocols. Hospitals with low nursing staff often have to fill positions with travel nurses, which is also going to put an added stress and burden on the workload of the staff nurses because they have to train the travel nurses on software, supply locations, orienting them to the hospital's locations and different floors and units, and other things. There may be a lack of teamwork or oneness, as well as contention, as the travel nurses have increased wages and they're only there typically for 13 weeks. This is just one of the graphics I included in my essay, which gives you a general idea of death rates in urban versus rural locations. This is for the whole United States, and it is specifically for heart disease. So it is not just mortality rates in ICUs, but you can see that the rural rate is much steeper than the urban rate. When comparing my data set from my essay and the research question I proposed, my interviewees and the scholarly articles that I read were pretty much on the same page. Essentially, it was just that a lower RN staffing rate and higher levels of admissions per RN are associated with increased risk of death during an admission to the hospital. The interviewees had similar views, just like I said, and one of the nurses I interviewed suggested getting any form of additional help, such unlicensed assistive personnel, medical assistants, LPNs, phlebotomists, or anything. Any ancillary staff that could help in any way. The other nurse that I had spoke to and interviewed, who has a 35 years of experience in an ICU, she agreed with the newer nurse's idea and simply stated that when staffing becomes a problem, errors and near misses become more frequent. She explained the importance of prioritization of tasks, such as running a critical drip over doing oral hygiene, but followed that statement with saying that if you constantly have to choose between prioritizing these tasks, these less important tasks are going to turn into more important tasks, because if you continue to neglect oral care or when dressing rotating patients, you're then going to have secondary infections and the creation of pressure ulcers and things like that that are just going to add to that increased likelihood of mortality in your patients. So for more avenues for further research, we could do cross-sectional analyses, which is different groups compared at the same time. We can also do longitudinal studies, which is the same group compared over time, and a meta-analysis, which is probably the most ideal research design to do. It would just take a lot longer. You need to have years of research put together and across different areas, different locations, and all of that. But it is a secondary analysis of many primary analyses, primary research studies that uses qualitative and quantitative data, and you put that together in a huge meta-analysis, just like it sounds. Additional research is always needed. It's never going to end, and the more studies we do, the more we're going to be able to find out. So we need to continue to do research and understand our staff so we can identify if and how the nurse-to-patient ratio is being affected and if it is in fact affecting mortality rates. When discussing quantum leadership and potential for personal and professional growth, in a general sense, quantum leadership embodies all things and places, and there's no hierarchy between members of the organization. Fundamental requirements of it include acting with moral purpose to make a positive difference in the lives of organizational members and society as a whole, building relationships that nurture both individuals and organizations, and making truly informed decisions by acquiring knowledge through listening to and empowering members. In traditional management, theorists always saw groups as systems through which goals were accomplished, and as such, they tended to lean towards hierarchies. In a quantum leadership view, we see things as we see parts of an organization and the members as interconnected and energetic beings, enhanced by collaboration and interaction. These connections are nonlinear and non-hierarchical. This view is supported by new sciences such as quantum physics, which suggests a different set of metaphors. The quantum paradigm holds that nothing is fixed, events are not predictable, control is an illusion, and change is continuous. And I would have to agree with most, if not all, of those statements. In an ideal setting, we'd propose and pass a policy that put a cap on how many patients a nurse is able to care for. But with that being said, it will be very challenging to implement a policy such as this in West Virginia due to staffing issues as well as high rates in hospital visits and an unhealthy population that we have here. Organizations could focus more on even distribution of acuity amongst the staff, encouraging downtime assistance, so when one nurse doesn't have as much to do, they help a nurse that has more to do, and finding ways to work with the staff that you currently have to make improvements until other research can be done and you can conclude why nursing shortages are such a dilemma in our rural regions. Trends and changes are never ending, so we must continue to conduct research, be present with our staff, listen to our staff. We have to understand their needs and meet those needs and implement needed changes as it presents. Thank you for listening to my presentation. Here is the list of references that I used to gather my data.